an oppositional defiant disorder. So these are field trials, and the purpose of the field trials that we have are to see, well, you know, there are two stages of field trials, by the way. We've just begun the first stage of these field trials to see if the revisions will remain stable over time. If they're useful to clinicians, that's a biggie. Are they applied reliably? Do they really help the process of diagnosis and assessment? I mean, so this is what's going to be looked at in the first iteration of these field trials. Now, this is another category which is very controversial, very controversial. So the idea was, just like we talked about the statins and high-risk syndromes, that is, that increase the likelihood of a serious disorder, are we there in terms of psychiatry? And there are two major risk syndromes that have been proposed, both very controversial. The first, a psychosis risk syndrome, to identify individuals who might be in the early stages of a major psychotic disorder. Okay, something in this is an area in which I've done a fair amount of research, and there are a couple of papers that might be of interest to you that we've just published, on this particular topic in terms of staging of psychotic illness. Now, personally, I don't think we should do this because I think the risks outweigh the potential benefits at this time, at this point. The reason being, because even no matter what criteria you use, you only increase the yield from 1%. I mean, the risk of schizophrenia in the general population is about 0.6%. If you use these ultra high risk criteria, you increase the yield to about 25%. It ranges from 50 to 40% depending on which studies you're looking at. But still, a vast majority will not go on to develop schizophrenia. So saying it's a psychosis risk syndrome and defining them, labeling them, if you will, and potentially subjecting them to interventions that may not have been necessary, that's the downside. The upside is, by the time many patients with schizophrenia first present for treatment, they have significant impairment already. A lot of the brain damage has been done, and the hope has been if we can identify them early and intervene early, maybe we could have really helped them. So that's the tension. But again, the field trials will help us. So these proposed changes, by the way, I think it's important for us to keep in mind that there's a long process ahead of us. These are proposed changes, and these changes are being field tested right now. There are going to be two. After the first field stage, there'll be another set of revisions that might be proposed based on the results of the field test. There'll be a second set of field tests, and then only then will DSM-5 come into being. This is temper dysregulation with dysphoria, and this is the driver. But we've discussed some of the concerns with that particular category. By the way, in terms of suicide-related proposals, there's a new suicide scale that is being proposed both for adults and adolescents, so that suicidality can be more accurately measured. Simple scales. None of these are 20-item, 10-item, 5-item scales. Most of these scales are 1-item scale, if you will, with reasonable anchors. Eating disorders, again, a lot of these disorders that were separately utilized in childhood are going to be subsumed with eating disorders themselves. Let me close up at this point. These are some of the cross-cutting dimensional measures that are being proposed for use across, for use in children. 8 items for pediatric depressive symptoms. There are about 6 items for pediatric anxiety symptoms, pediatric anger 6 items, 6 to 8 items actually. That's why you've got that asterisk there. 6 items for pediatric anger. This will be simplified to kind of make it a single item cross-cutting measure, because all cross-cutting measures will only have a single item, ultimately, a single rating on a 0 to 5 scale. We've talked about this. Changes in DSM-4 were not responsible for this. Changes in DSM-4 criteria were responsible for this. So changes in classification in criteria do make a difference, which is why it's important for all of us to be engaged in the process, to know what's going and participate. If we have strong opinions, if we believe that certain errors might be made or certain things are not being considered, I think it's very important for us to engage in this. This is relevant to what we talk about because most of if you look at the guidelines that we develop, they're organized around diagnoses. These are our guidelines that we'll be reviewing over the next couple of days. Our guidelines for ADHD, our guidelines for treatment of depression, our guidelines for the treatment of bipolar disorder in children, adolescents. We've got one on use of these different classes of meds. So essentially, diagnosis is relevant to our process over the next couple of days. And as we think about the different classes of medications and how they map onto different disorders or different target syndromes in different disorders, these are the issues that we'll be reviewing over the next couple of days. And in my mind, I think this is what's always driven our process, that it's not an issue of are we using too much of this or too little of this, but we should be using treatments appropriately, including medications. And the issue is always one of appropriate use, which means it should be informed by evidence. It should be informed consent is a very important, is a bedrock of use of these medications. It should be individualized, and it should be carefully monitored. Both the benefits and the adverse effects need to be monitored, and there are different ways of trying to make that happen. And ultimately, whatever recommendations anybody comes up with, ultimately the decision about use of a treatment is one made by the child, his or her parents or guardians, and the prescribing clinician. So this is the first stage. Second stage trials. Let me actually, so field trials right now, phase 1 for the next year, and then phase 2 will begin after that, and in middle of next year, again, revisions might be proposed, additional changes might be proposed based on the findings of the phase 1 field trial. And again, they'll be posted for public comments and changes made and incorporated into phase 2 trials. And then the final draft criteria will be prepared in the middle of 2012. And then the assembly will review the criteria in November of 2012. And then hopefully the trustees will approve it in 2012, and it'll be released at the APA annual meeting in San Francisco in May of 2013. So thank you all for your attention, and I look forward to any additional questions, comments.